David and Helen meet with the thoracic surgeon, Professor Tom Treasure, to find out more about the surgical aspects of the trial.
Well, I mean, first, thank you very much for seeing us, Professor Treasure. It means a lot to us that you're taking time to do this, so thank you. I think Dr. Leonard and Hayley, the nurse specialist, have been really clear with us about PulMiCC and about the whole process and where we're at and the options, and very fair. But when we spoke to Dr. Leonard last, we're still in a, oh, what do we do, if only somebody would make our mind up for us, really.
Don't to do the wrong thing.
No, exactly. And what I would like to know, what we would both like to know, is really from you. I mean, do you think that the trial is the right way to go?
Well, that's the key question and a very important one for you to be confident about. Well, I believe the trial is an important trial, and the question is whether you are in a position of sufficient uncertainty about which is the best route to go in, or that we are in that uncertainty, that it is an even choice between which route you go. And having looked at all the tests, certainly many surgeons would be quite happy to remove those secondaries that are in the lung. What we all lack is good evidence to say taking them out is better than leaving them alone. And that's exactly what we want to find out. Now, I realise that to admit to not knowing what to do for the best, it's hard for doctors actually, and quite a lot of them find that extremely difficult to do. And of course it's rather baffling for patients, because a lot of what we do depends on having trust that we're doing the right thing for you. I think even more important is to be clear when we are genuinely unsure which is the right course to go. And here it is the choice between having an operation, which it's not very risky, that's not really the point, but it's unpleasant to go through. It'll take a period out of enjoyable life while you're in hospital. And who'd go through that if it's not going to make any difference to the outcome at the end? And there is real doubt about that.
I think we do understand that both you and Dr. Leonard are, as you put it, genuinely uncertain.
Sure, yeah.
And we appreciate that and we respect that. It's just I have the feeling if we went up to one of your colleagues, say in London, one of your surgeon colleagues, he or she might say to us, no, go ahead, have the surgery. Never mind PulMiCC, have the surgery.
Well, they might well. Now, depends on how much detail of the background of the trial you want to go into, but I'll go in as much as you like. I'm very committed to it, and it's a subject I know very well. The practice of taking out secondaries from the lung has been going on for about 40 years. So it's not a new or experimental thing. And it started off that there were people who had just one isolated secondary, perhaps from a rather indolent cancer, and it was removed, and they would be alive some years later. And the conclusion was drawn that it was the operation which gave them that longer survival. And it might have been. Well, now, as with colorectal cancer, it's becoming very common. It's one of the commonest cancers, and it's the only one of the common cancers for which removal of secondaries from the lung has become pretty well routine practice. But it's grown into an area of uncertainty slowly, just bit by bit over the years. Now, people do it, of course, because they believe in it, and patients like to feel they're rid of their cancer. And that's perfectly understandable. But those nodules that we can see now, we can look at them on the screen in a moment, must have been seeded at the time of your original cancer, which was about 3 years ago. And they've been growing since, and there may be others. And if those are genuinely the only two that you have, removing them could finally cure this cancer. But in the majority of patients who have surgery, other secondaries come to light over the next few years, and the cancer runs its course. So 2/3 of people who have this operation are not alive 5 years later. So it's far from unclear. And even then, the patients put through this type of surgery are right down at the level of about 1 in 50 or 1 in 100 in the published series. We know that it isn't a cross-section of people. And it could be they were long survivors anyway. So now, as this practice is getting more and more common, more patients are put forward for it, for more secondaries, an earlier time, it could easily be that we're doing at least as much harm as good, or maybe more.
You see, this is the baffling thing, because you might not know I'm a journalist on a local newspaper. I'm only the arts correspondent. But my colleague, who's the medical correspondent, Jeff, he did a bit of internet research for me on this, and he said that it's clear that in the States at the moment, once again, it's, yay for surgery. They're all moving forward. That seems to be the way to go.
Well, indeed, and it's precisely that has made me and others want to study this. Now, if you take, for example, other cancers, and one of the common ones is breast cancer, when I was a trainee, massive operations were done for breast cancer. Not just removing the whole breast, but stripping out areas here, going into the chest and so on. And there was a retreat from that in the 1980s. And it was a retreat from a position which people believed in. So if now, 20-something years later, we look back and say, they had that wrong. There are things we are doing now, which we do in good faith, and surgeons do in good faith, but are not beneficial. So we have to keep not only making progress, but sometimes retreating from things which are not right and are not good. Now, I cannot tell you, if I could convince my colleagues on the available evidence that the removal of the metastases from the lung is completely unavailing, if I had the evidence, I would tell them that. When I have raised the question to them as a researcher, they say, but we might be helping. And patients want to be helped and they want to get rid of their cancer. So I do see it as something which is a serious question to be addressed and genuinely not known. And just because they do it in America doesn't necessarily make it right, of course.
That's true. So it's just hard for sometimes you reach the point where you just want somebody to tell you.
Yeah, but it's almost like, what would you do?
What would you do?
Well, I could tell you that is true. And under these circumstances, I do know that having a decision made can be helpful. Even, sometimes when you're very uncertain, you sort of toss a coin and say, shall I do this or shall I do that? Shall I buy the house or shall I not buy the house? And it helps you make your mind up and clarify things. And in truth, within the randomized trial, the decision is made for you. Either course could have its upsides or its downsides. But we have done everything we can to be sure that people entering one group or the other group are as likely as each other to eventually do as well. And as soon as we think it's going one way or the other, or the committee's working for us behind the scenes, because we won't be looking at that all the time, say, hang on, it's going this way or it's going that way, then we'll stop. So all I can tell you is we wouldn't be doing the study if I didn't, really think that your chances with one route were as good as with the other.
Yes. Well,
so, any other questions that I can help with while we're here?
Yes, you've been really helpful on the uncertainty issues and made that as clear as we could have hoped. We do have a couple of questions which are worrying, especially worrying Helen, I think, really, from the patient information here. This is, tells us a little bit about the surgery, but not very much. And you had a question on the extent of it, really.
Yes, really, because apparently these two lesions are very small. So I would have thought that you'd only be taking a little bit of the lung away because there's not that much to remove. And yet it says that there could be quite bad breathing problems as a result.
Yes.
So I don't quite...
Well, remember that the patient information sheet is written to cover a wide range of eventualities. Let's just look at yours, if that would be helpful.
Oh, yeah.
And this is the CT scan.
Yeah.
And with the CT scan, it's like a slice across, and you're looking at it as though it's from underneath. So that's your right lung. And this is where your heart is in the middle, and there's the airway just dividing to right and left. Well, there they are. So they're about that big. Now, you see how big the lung is, and that's just one slice that goes from top to bottom. If you just take those out with little margins or wedges like that, it will make hardly any impact on your lung volume.
Yes.
And that's your lung capacity. On the other hand, if somebody had a rather big one in here, and in order to safely remove it, they had to have a whole lobe of the lung removed, then you would lose more. I'll just draw that for you, what that means. You see, those ones are out there in your right lung. So there's a couple of things out there, and they might just come out with a little wedge of tissue like that.
Yeah.
Now, another person might have something right in here, and in order to get rid of it, they might have to lose, say, half of the lung. And that would be a much bigger loss of lung tissue. Now, the other thing about it is that the approach can vary. So this is just the amount of lung you lose. But if we were able to go for those with keyhole surgery, which is 3 small incisions
That's
about
my
that big.
second question.
Okay, well, shall we deal with this first? And this is to do with the lung capacity issue. In your case, it's not
Not
much,
so bad, no.
but for some people it could be a lot.
Yeah.
But let me just complete this bit, because you see, also here you have to cut into lung tissue, and after you've done that, the lung can leak air. You have to have a tube in there, there can be fluid, so you can have complications even though you've lost a small bit of lung. So it isn't the long-term loss of total lung capacity, but what we hoped would be a 2-day stay for a keyhole operation could be a week or a 10-day
It's a
stay.
bit more.
They're two different issues, but they're different between
But in
these
terms
two.
of my breathlessness, which is what, because at the moment I don't
He
suffer
doesn't
from
have
it.
any of that.
And we know your lung function is good and there isn't a problem and you're a fit man. So in terms of long-term lung disability, in your case, the risk is extremely small.
Oh, that's...
So that doesn't
Yes.
quite apply to you.
You
Right.
did,
All right, and the
you
next
touched
question.
on,
Yes.
on my other question,
Yes,
Professor,
yes.
which is that it's clear here that there are these two possibilities. That one is the keyhole and the other is the thoracotomy. Thoracotomy. Now, my question is this. If I go into the PulMiCC trial,
Yes.
can I choose which of these methods I have?
Well, to a large extent, the factors that in general, the issues are technical, so that is amenable to the one and that isn't, and vice versa. But also, the surgeon may have other reasons to have a bigger look at the lung, that he's suspicious and wants to inspect it all, or that he's worried that there may be any other spread somewhere else, and he wants to have a full thoracotomy. So some surgeons, under certain circumstances, would give you a strong steer in one direction or the other. Quite honestly, if it just came down to a matter of your choice, who'd choose to have the big one, then they could have the small
Yes,
one.
of
So
course.
indeed, I mean, that's in our minds too. So unless there was a strong reason to do with the technical access or something else, which the surgeon would explain to you, then it would be done that way. And indeed, if I were doing this operation for you, I would want to do it the keyhole approach without any question. And if you said to me, couldn't I have the big one, I'd think, why is he saying that?
Yeah.
You know, I'd have to say to you,
Right.
what's worrying you? What is the point behind that question? So it tends to go that way.
So, if you did go into the trial, and he got the surgery option, you'd be the one who would do it, would you?
Yes, very likely. I'm one of the surgeons who looks after the practice. These are planned operations, so you'd be put down on my list to do on my day, and it would be me and my team there doing it. Occasionally another surgeon takes over, but you'd know that was going to happen for good reasons, but yes, basically.
It's quite important, really.
Yes.
Good, well, that's been an interesting discussion, and I think the points you brought up are just on the button. You know, these are the important issues. Now, between what we've discussed today and what you've heard elsewhere and in the information sheet, do you think you're at a point where you'd be ready to join the study?
Well, I think I am.
I think I am.
Yes.
Good, I'm
Oh,
pleased to
yes.
hear that.
For sure.
That's good.
Absolutely.
So what we need to do now is go through that process of randomisation. And Hayley's here in the clinic, and we have everything is now in place. Your agreement and our continued feeling that you're eligible for this study, so we can do the randomisation today and let you know what the answer is.
That would be good. When would they let us know?
Well, we can usually let you know straight away.
Okay.
The randomisation is done by telephone so that the allocation in the computer is off our site. That's to be sure that nobody inside can contaminate it in any way, and that it's absolutely even-handed. It always is, but that's the best process. Provided that telephone communication is made smoothly and we're in office hours, we'll get an answer on that phone call.
The sooner I know.
Yes,
Yeah,
indeed.
yeah.
Oh yes, it's this
time to
uncertainty
make the
for you.
decision
It's
to
difficult.
jump in, isn't it? Yeah, for
Yeah,
sure.
and then you know where you're heading and you
Yes.
can pick it up from